Hello, everyone, and welcome to Talk Nerdy. Today is Monday, December 22nd, 2025, and I'm the host of the show, Dr. Cara Santa Maria. And usually we would be on hiatus right now. I tend to like to take 2 weeks off over the holidays, but I got an opportunity that I absolutely couldn't pass up, and that's why I'm here with you now during this special episode. So before we dive into today's show, I want to take a moment to ask you to stand with me for a good cause. I'm joining 30 and counting podcasts in the Pods Fight Poverty campaign. This is a team effort to raise money for Give Directly. And you may remember Give Directly because I interviewed Dr. Miriam back in 2022 about this incredible organization. So Give Directly doesn't build infrastructure. They don't dictate how aid gets used. What they actually do is send unconditional cash transfers directly to families living in extreme poverty around the globe. They give real people the dignity, stability, and choice to decide what they need the most for themselves. With Pods Fight Poverty, the goal is to raise enough money to lift 3 villages in Rwanda out of extreme poverty, giving families the cash that they need to buy food, safe housing, medical care, education, start a small business. They know what they need. So if you're able, please consider giving at givedirectly.org/nerdy. That's givedirectly.org/nerdy, because truly every bit helps. And with that, I thought it would be the perfect moment to revisit that favorite conversation that I mentioned from the archive, my 2022 interview with Dr. Miriam Lecaire. She's a public health physician and the former director of research for Give Directly. In this episode, we dig into the science, ethics, and real-world outcomes behind direct cash aid, and why trusting people with resources can be one of the most transformative interventions that we have. So without any further ado, here she is, Dr. Miriam Lecaire. Well, Miriam, thank you so much for joining me today.
Thanks, Cara. I'm excited to have this discussion with you.
Me too. So when I first heard about the work that you do, I was thrilled and immediately said, yes, we've got to get her on the show. And it's going to take a little bit of unpacking because you've really put your effort and your energy at such a young age into so many different areas. And so I'm just, I'm fascinated to hear about all of the incredible, important work that you do, not just in Uganda, but really you're making an impact sort of across East Africa, across, the globe. So let's start with where you work now. You are a medical doctor and your focus is in tropical medicine?
Yes, so my focus is in tropical medicine and specifically research around tropical medicine and cancers that are common in the sub-Saharan part of Africa. Those are Kaposi sarcoma and cervical cancer.
Okay. And so you focus quite a bit on research. Is that into incidence, epidemiology, prevention, treatment, all of the above?
Yeah, so the research that I was doing was focused on all of the above. Initially, we started off with a focus on treatment, but we very quickly realized that for us to be able to get patients at an early stage, we had to go backwards and start off from the point of prevention, early detection, treatment, and then general education.
Right. And so now you're working at Give Directly. Will you give us kind of an overview of what Give Directly is, and then we'll go back in time and see how you got to where you are?
Absolutely. So Give Directly is an international charity that delivers cash to people living in poverty. We like using the term delivers because we get donations from individuals, from organizations, and so we deliver that cash to people living in poverty. And what Give Directly believes is that recipients, we call the people who receive the cash recipients. We believe that recipients or people living in poverty know what is best for them. And as a result, the model that we use for cash transfers is unconditional cash transfers. We do not tell our recipients what to do with their money. We believe they know what to do with it. And I like giving the example to people Just take an example of the price of gas. It's high all over the country right now. And so I normally ask people, can you imagine if your employer decided this month that because the price of gas is really high, they're going to pay even part of your salary in gas? You'd be absolutely furious. And so I say, exactly. So if we don't want that to be done to us, why do we want to do it to people living in poverty? Let's give them cash. And the great thing about cash is that cash is fungible. It can meet multiple needs in multiple people at the same time. So that is the model that Give Directly uses. And we are right now running operations in up to 11 countries around the world, in the US and in Africa. And we are opening up operations in Asia as well.
So it's fascinating to me because it seems to me to be the case that time and time again, this is an evidence-based approach to prevention of all of the negative consequences that come along with poverty. So this is an evidence-based approach to public health. It's an evidence-based approach to prevention of criminal behavior. Yet time and time again, you see a sort of ideological push away from monetary infusions and an ideological push away from no strings attached. You know, in America, we see very often, even with our entitlement programs, with sort of like welfare programs, that there will be drug testing that people have to do, that they have to check in with different officers on a regular basis, that there are a bunch of hoops and barriers that actually cause people to lose their rights to this cash and ultimately land them in a worse position than when they started.
Right. Right. Absolutely. I think the funny thing about cash, Kara, is that people are more willing to give things in kind. Even when you look at normal relationships, people are more willing to buy you a present when they need to give you a present. But once you
Mm,
ask people to give it to you in the form of cash, then people hold back. And I think this attitude is now spreading across into the aid world. We are more willing to give donations in kind, but once it comes to giving cash, then we begin to say they're not going to use it well. The hopes that people have to jump become really high and several. And I think
mm,
that is a problem. And I believe that also speaks to the fact that to date, cash transfers are the most studied intervention outside the medical field. People
mm.
over and over are looking for evidence. Does it really work? Are people not spending this on temptation goods like drugs and alcohol? To me, it is really a paternalistic way of doing things. Why do we think people living in poverty do not know how to spend money on the right thing?
Absolutely. It's paternalistic, it's colonialist, it's and you
Yes.
see it in the most basic examples of, you know, somebody panhandling on the street. You see a lot of resistance to giving cash for the very reason you mentioned. Oh, somebody's just going to buy drugs. Oh, somebody's just going to buy alcohol, which I mean, I don't know. My view has always been, yeah, okay. I think if I was living on the sidewalk, I might need help to sleep too. You know, I'm not going to judge, but ultimately, it is this really damning resistance that people have. And I mean, I just covered on another podcast I work on, The Skeptic's Guide to the Universe. I just covered, and you probably saw coverage of this as well, a big study out of Monrovia, Liberia about criminal recidivism and really
Yes.
taking the most potentially violent offenders and giving them cognitive behavioral therapy and cash. And that was a winning combination. CBT on its own worked, but not for long. Cash on its own, a little bit, okay. But when they added CBT and cash, 10 years later, it seemed to have an effect with this group of individuals.
Absolutely. Absolutely. And that's the amazing thing about cash transfers. You can use it for anything that you need as a person. And also it addresses many different needs. So these are people who were violent criminals and it addressed the need that they had. You would go to a community, find a single mother with a lot of young children. It will address her needs. So I love the fact that cash is cross-cutting. Everybody needs cash in one way or another.
Yeah, and I love the example that you used as well because I've seen some pilot programs here in the US, and again, there's sadly a lot of ideological resistance to them, but that the single most helpful intervention for women who are trying to flee abusive relationships is cash. That very often they are trapped because they don't have financial freedom. But if they are able to get their own home, get their own apartment, get their children safe in a new community, and that takes money, that very often they can set a foundation that then they are able to find work and make their own money. But it's that initial hump that seems to be the hardest part to get past.
Absolutely. And Kara, that in a way that relates to the reason I essentially moved from medicine into development economics and specifically in the cash arena.
Hmm.
When I started doing medicine right from medical school, when we started interacting with patients, one thing that was very clear was patients who were poor had worse outcomes. They came to hospital later, they could not afford the treatments. And so as a result, they had worse outcomes and then repeated infections. And so you look at it and see that a patient that presents with the same condition but has money has a lot of options before them. And one that
Mm.
doesn't have money has absolutely zero options. And so it really speaks to why I moved into this field and said, can we give people cash and will make a difference in so many areas of their lives, not just health, but in just multiple facets of their lives. And we see that a lot in Give Directly when we give people living in poverty cash and go back to them and ask them what the cash did for them. I mean, it's just a rainbow from buying livestock, and even the livestock is not just one, it's going to be goats, pigs, chicken. There was one particular recipient in Kenya that I love, and he simply said, "Not everyone wants a goat." Most of his community was exactly, most of his community was buying goats and other forms of livestock. And he was like, you know what? I love music. I know how to play instruments. And he started a band, bought instruments, and now that is what he does to make money for himself. So that is a great thing about cash.
Oh, I love that. And so tell me how it works at Give Directly. Who do you serve and who comes to you with need? Is it all over sub-Saharan Africa? Is all over the continent? And kind of how do you decide who you are going to partner with and who the recipients will be?
Okay, good question. So before 2000 and before last year, we did not have what we call a country office in the US. All our country offices were in Africa. What do I mean by country offices? So these are offices, these are countries where we have operations ongoing, and we have projects where we identify communities living in poverty and give cash to them. Our projects are multiple. So we have what we call our retail projects. Retail projects are those where within a particular country, we identify communities living in poverty. We do that usually using census data because it's the most objective form of data available out there. And then
Mhm.
when we identify a community, we do what we call saturation. We do not specifically target the poorer households within those communities. So this is a lesson we learned several years ago when our operations had just started in the first country in Kenya. And what we did at the time was we targeted households based on the nature of roofing they had. And we naively thought houses that had grass thatched roofing represented the poorest in the community. But we later on found out that sometimes you have someone living in a brick house with a metallic roof, and yet they inherited it from someone and are living in poverty. And then
Mm.
the other thing that happened as well was, so now you're in this community, some people are receiving cash, some are not receiving cash, and cash is a very high stakes aid. People are less bothered when some people receive food, for instance, and others don't. And so we quickly found that this led to conflict in the community. So now when we go to a community, the entire community is eligible for cash transfers, and everyone in that community will receive cash unless they opt out for whatever reason. So those are our
Oh.
retail. Exactly.
Yeah,
Now,
so you kind of have a more holistic, and then the idea here is that, right, a rising tide sort of lifts all boats within that community.
absolutely, absolutely. And when you think about it, Kara, because sometimes we get a bit of backlash on this, the people who are defined as non-poor in these communities are actually really poor as well. So, because
Mhm.
the cutoff we're looking at is $1.90, we're using the World Bank cutoff for extreme poverty, $1.90. But someone who lives on $1.90 per day is not very different from someone who is living at $1.70 per day. So usually all the people in the community are really poor to one degree or another.
Yeah, yeah.
Yes. Mhm. And then the other projects that we do, sometimes we partner with organizations that are interested in learning about cash or giving cash to the communities. Many times, those partner organizations have specific demographics of interest. For instance, we may be working with an organization whose interest is children. In that
Mm,
case, we saturate the community in a different way. We identify in that community all the households that have children that meet the required demographics of the partner, and then we saturate all of those households. This is usually easy to explain to the community because we say this organization that is giving us the cash wants only households that has children, for instance, 5 years and under. So that is very objective. The entire community understands that, and we do
yeah.
not end up getting conflict in that case. Finally, we also partner with institutions that are interested in research to learn about cash. For instance, we've been working with USAID um, in what we call benchmarking studies to compare the impact of their programs to the impact of cash transfers. Just recently, we had the results of a research project that we conducted in a refugee settlement in Uganda just come out as well. So those are some of the multiple projects that we do.
Oh, interesting. And so, with, for example, the USA AID program, is the idea here that you tried to find as close to as you could, like a matched control, so that you could sort of compare community to community with these two different aid models?
So what we have done with the USAID benchmarking studies, as we call them, is we go to communities and some of the community receive the USAID intervention. Let's say it is youth skilling for employment. And then other communities in essentially the same area receive cash transfers that are equivalent to what it costs the USAID project to implement the youth skilling program for one person. So it's really cash equivalent programs. And sometimes we have a third component, a third arm, which is the USAID intervention plus cash. And so we want to see how cash performs or the USAID intervention performs in that setting. And usually we compare them to another group, which we call the control arm, that is receiving neither intervention.
Mm-hmm.
Yeah.
I'm curious, and this is just a random question that sort of arose as you were describing that. It seems to me the case that with traditional aid, which very often involves training or involves a lot of oversight to ensure that certain types of funding are being used in the way that the funders deem appropriate, this very kind of paternalistic, as we mentioned, approach, which historically has been the leading approach, it seems to me that there are a lot of sort of externalized costs. There's a lot of labor involved. There's a lot of paperwork involved. There's a lot of red tape involved. And so we talk about barriers, of course, to the actual recipients. But on top of that, it seems that cash would really streamline like charity. It would streamline giving in a way that is almost hard to measure.
Absolutely. Kara, you're absolutely on the point right there. So in Give Directly, one of the things that we look at is efficiency. So what proportion of every dollar that we receive ends up in the pocket of recipients? And because the model that we use is we send cash directly into people's cell phones, we don't have people out in the community distributing cash, which is something you cannot do with in-kind aid. You need someone out there distributing
Mm-hmm.
the aid, making sure. So you're purchasing stock, you're transporting stock, you're distributing it. There are just so many layers. And at Give Directly, we say all this cash that is used for all those parts of operations could really be cash that ends up in the pocket of recipients. So why not use cash? Because the efficiency is extremely high. In some cases, we've had efficiencies of over 90%.
Wow. So in that case,
Yeah,
the recipient benefits significantly
absolutely.
more.
Absolutely.
So I'm curious, and I just want to clarify something for the sort of American audience who's very likely listening, or English speaking world audience who's very likely listening and thinking,
but you said these individuals are living in poverty. They have cell phones. Everybody has a cell phone, right? Like we're living in a world now where access to cell phones seems to be more ubiquitous than access to healthy food.
Exactly. I'll tell you something interesting, Cara. A while ago, because I did part of my training and fellowship in the US, so I have a lot of friends
Mhm.
who are based in the US. So recently, one of my friends was looking for a cell phone that had no internet access for their child. And no one seemed to know. And I was like, guys, there's cell phones that have no internet access. So I had to like take a picture and share. And someone was like, what is this? So coming back to exactly. So coming back to what you just said, there are a lot of really cheap cell phones. I mean, 30,000 shillings a cell phone in Uganda, for instance, is less than $10. And a lot of
Mm.
people have access to these cell phones. And then using what we call mobile money. So these are like really a banking system that is created by the mobile technology or mobile cell phone providers. People are able to have access to those small banks within their phones. The other thing Give Directly does is when we go to a community, we give the recipients the option of getting a phone. And the phones are about $10 as well. And if they want to receive a phone, then we take that $10 out of the total amount that they were going to receive. So just for the record, Give Directly gives equivalent of about $1,000, give or take, to every household that we transfer cash to. So $10 out of it is a really small proportion.
Oh, for sure. And so how does it work? Is it just one lump sum right at the beginning, or is it, a certain amount per month or per year until it's paid out? Or is it kind of vary depending on who the recipient is?
So the Give Directly model, what we prefer is lump sum cash transfers. We don't
Hmm.
do the lump sum as one transfer. So most of the time we have three transfers. The first one is a small amount, just to make sure that the recipient is able to receive the cash on their phone. And then after that, we break the transfers into two, sometimes three transfers, but usually two lump sum transfers on consecutive months.
Oh, okay.
However, because at Give Directly, our first value is recipients first, we've been talking about recipient choices around this. Because while we are giving recipients unconditional cash transfers, we're saying, is it possible for us to also model our operations around recipient needs? And so we
Mm.
have now started projects to actually establish from the recipients how they would prefer to receive cash transfers. We started off with a set of focus group discussions in three countries, Kenya, Malawi, and Liberia, about 200 past and future recipients, and asked them how they would like to receive their cash transfers. So if you're going to receive $1,000 in 1 year, in 12 months, how do you want to receive it? How do you want it broken down? And when do you want to receive it? And the findings have been absolutely interesting. We will have it up on our website very soon.
Oh, very cool. Yeah. So instead of and obviously it sounds like it's much more from a logistical perspective, the way that the cash infusions happen right now. But obviously, instead of again making assumptions about what is best for an individual that we don't know, um, asking the individual themselves, do you need, this big infusion because it helps you with some sort of huge expense that will get you moving, or would you prefer to have smaller infusions over a longer period of time because that would help you with your budgeting needs?
Absolutely. And I think this is really important for us to think about because most of the time when aid operations are being developed, we look at the convenience for the organization. And yet
Mm.
we really need to be thinking about the impact we are trying to achieve with our intervention. And so we're thinking more and more at Give Directly that if we give recipients or the beneficiaries the chance to make a decision about when they want to receive their cash transfers and how they want it to be broken down, then maybe it will be more impactful for the goals that they have. So lots of
Yeah.
interesting discussions going on around this.
And I know that there's no kind of one answer to this because clearly economies across the continent are different. But for, again, the people who are listening from America, the UK, Australia, from English speaking countries, how would you say, on average, $1,000 in, let's say, East Africa, in Uganda specifically, what is the weight of $1,000? Because I think it's sometimes hard for individuals to think on scale when they're used to their personal cost of living and their own income.
So I'll start by giving the broad response that we normally give. We say, from my experience, we find that $1,000 is on average what an average household needs for the consumption for a year. However,
Mm.
I love responding based on the experience that we have had with Give Directly. People are able to build houses with $1,000. My first trip to the field after joining Give Directly was about 4 months after I had worked with Give Directly. And I went out to Kenya to a community where we had recently given cash transfers. And people were building houses. So communities came together and the men were in charge of putting up the structures. And then the women would also create groups and come and plaster the houses together. So amazing. People are building houses. Some of them are just improving the quality of their houses, like changing, a leaking grass thatched roof and replacing it with an iron sheet roof, because then they're able to get clean water, meaning they're also going to buy a big tank as well to capture the
Mm.
rainwater for use as a family. People are buying livestock. Others are buying motorcycles. So the motorcycles are used quite a lot in East Africa as taxis, as cabs. And so people are buying,
Mhm.
yes, so they're buying these to, buying motorcycles for that. People are opening up businesses. I mean, it's just amazing, buying land. So $1,000 actually goes quite a long way in our setting.
Wow, and it really does seem to be the case as you're looking at the data that you're actively receiving and analyzing, that these cash infusions are really serving for many people as investments in their future, whether it's their home, their career, their health, their livelihood. They're really investing, and so these cash infusions are giving back many times over.
Absolutely. And in one of the research studies that was done by Give Directly as well, we found that these cash transfers have a spillover effect into the community. And what happens is that households that receive cash, of course, are going to use it in the community. You receive $1,000, you will spend it in the community. And so at the end of the day, even those people who have not received cash will benefit from the boost in the economy that this $1,000 brings. And we actually found out that there was a multiplier effect of about 2.6, meaning for every dollar that we gave to these communities or that we transferred to these communities, it multiplied itself in one way or another by 2.6. So it's just amazing the impact that it has, not just within the household that received cash transfers, but in the community at large.
That's incredible. And I feel like so often from a political perspective, that return on investment, that ROI, that multiplier effect that you mentioned is like a single, one of the single most impactful selling points, to say, listen, for every dollar that we're giving directly, we're seeing a $2.60 in returns. Like, that's massive, and it's very hard from a purely kind of evidence-based scientific perspective to ignore that. So one thing that we didn't mention, which we probably should, is that at Give Directly, you serve as a research director, the research
Yes.
director. So tell us
Yes.
what that means. I mean, clearly you have a good handle on a lot of the research, but are you developing these research projects? Are you analyzing the data? Do you have a team? What does it mean to be the research director?
Great question. So, Give Directly is an organization that believes in translating evidence into practice. That's the first thing. So, whether it's evidence that we've generated ourselves around cash or evidence that other people have generated on cash, once we think that it is worthwhile, we move it into operations. So, as a research director and my research team, that is one of the things that we're tasked with. So, finding out evidence that exists and informing the organization on how we can implement that into our operations. The other thing that I do as research director is providing oversight for the research projects that are happening at Give Directly. Most of them are what we call randomized control studies. They are experimental studies We run these with, usually they are evaluated by people external to give directly. So there may be research companies or academics. And the reason
Mhm.
why we prefer that these projects, these experimental studies are evaluated externally is really because we want to avoid conflict of interest. Because in a way, in a sense, we are the intervention. So we are the ones that are delivering cash. And so you need an external party to come in and evaluate whether or not the cash transfers worked. The other thing that we do as a research team is to come up with novel ideas. Look out for the gaps that are present in the research field, in the cash research field, and come up with ideas, research ideas that can eventually be implemented. And then we also, as a research team, do monitoring and evaluations for all projects that we run, both internally as Give Directly or with partners that come to Give Directly.
So I'm curious, before you trained as a medical doctor, and I know that your specialty, as you mentioned before, was tropical medicine, and specifically the research methodology behind sort of these different interventions. But before you trained as a doctor, did you study science? Were you into biomedical science, or because very often, and this is just my own bias, I come from kind of a lot of academic science. Very often, physicians don't have a lot of scientific training. That's not really the way that they came about, especially here in the US. Some physicians for sure do undergraduate degrees in the sciences, but very rarely do they do advanced degrees in the sciences. And even sometimes their undergraduate degrees are very clinically oriented. And so they don't have a lot of research methodology experience.
Right. So most of my research methodology experience was after my undergraduate, my first degree in medicine. So the way
Mm-hmm.
I got into research was, I remember one of the things that we used to say in med school and as residents was diseases happen in threes. So if you saw a rare condition, the chances that another two would come in within that week was really high. And then, so I always used to ask questions. Why is it that things happen like that? And I remember one of my bosses told me, you know what, Miriam, maybe you need to think about doing research because you'll be able to answer you have a lot of why questions. And so I did,
Mm-hmm.
yes. So I did my first master's program in the London School of Hygiene and Tropical Medicine. It was in tropical medicine and international health, but it had a heavy research component as well. And then later on, when I got involved with work with the University of California, San Francisco, I also had a master's in advanced studies focusing on research and epidemiology. So that is how come I do both clinical work, but also heavily involved in research.
I love that. And I love that your professor was like, maybe you should do some research because you're asking why a lot, which goes to show that a
Exactly.
lot of medical students don't ask why questions. Oh, I love that. I think that's fascinating. And so even before you came to Give Directly, you were working as a researcher in let me see, the United States East Africa HIV associated malignancies research group. So is this where you were doing a lot of the cancer research that you mentioned?
Yes, that is where I was doing it. So we were doing it in Uganda, in Kenya, in Tanzania, in Malawi, Botswana, and Rwanda, because those are some of the countries that have the highest rates or incidences of the two cancers we were working on, Kaposi's sarcoma and cervical cancer.
And those two cancers specifically are associated with HIV infection?
Yes, they are.
Ah, okay. Yeah, yeah, yeah. And so I'm curious, for individuals who have probably sadly aren't keeping up, are distracted by, all of the things across the globe that are so easy to be distracted by. And I know this is a bit of a left turn question, but I'm curious how pernicious, how um, intractable, uh, a problem is HIV and AIDS still on the African continent?
That's a very good question, Kara. So HIV has come to a place where a lot of people have ignored it because it's been around for so long, and then there's
Mhm.
antiretroviral therapy, so everyone thinks the problem has been solved. However, when you work in a country like Uganda, in East Africa, or in Africa for that matter, you see very quickly that there are people who still do not have access to antiretroviral therapy. And even those who have access to antiretroviral therapy have minimum access to virologic testing. So virologic testing now is officially the best way to monitor if someone is responding well to treatment. But because it's expensive, people in Africa get their viral loads tested maybe once or twice a year. That's what the governments can afford.
Oh, so this is like how many T cells you have?
No, so this is no longer T cell. So research showed that just the T cell count is not sufficient to tell that you're
Mm.
responding well to treatment. So this looks at the viral particles that are in
Oh, the
circulation.
act. Oh, so it's not just your
Ex-
immune response; it's the actual viral
Absolutely.
load. Okay, okay.
Absolutely. Yeah, but it's expensive. It is right now, it is the standard of monitoring, but because it's
Hmm.
expensive in the African setting, it's usually done once, if you're lucky, twice a year. The other
Hmm.
thing is that we are still battling a lot of HIV associated illnesses, for instance, cancers. We're thinking more and more that it could be because of what we call immunosenescence. And what does that mean? It's been found that HIV leads to aging of the immune system. And so
Mm.
whether someone starts on antiretroviral therapy and they're virologically suppressed, their T cell count has gone up, the T cells are actually aged. And so you
Mm.
have young people beginning to present with diseases of older people. And so that is why we think people are having a lot of these cancers that you otherwise would be seeing in much older people.
Oh,
Yeah.
interesting.
Mhm.
And so this problem, I mean, it's not gone.
No.
It's in some ways just well, in some ways it's the same as it ever was, and in other ways it's just reinvented itself. It's we've now understand the problem better, so we know that there are new fronts that we have to sort of fight on.
Absolutely. And there's a saying that one of my professors used to say that sometimes we just get used to bad things. And I
Mm.
fear that that's what's happened to HIV. There's a lot of funding fatigue around it. People are more interested in funding emerging diseases. And so HIV is suffering from lack of funding. And it's worse because in most African countries, we rely entirely on donor aid for HIV management. And therefore, and the governments are not supporting HIV care. And so then we are on the beck and call of the Western world, because if they removed funding, then we would be in a crisis around associated with HIV. Because with HIV, once you're not on treatment, then it just begins, the virus begins to multiply, and then you'll go through the natural process, AIDS and death.
Yeah, and
Yeah.
I mean, it really does seem to be the case, and I don't know if statistically this is true. Maybe you can tell me that HIV is potentially the longest, most persistent um, global pandemic uh, of our time. You know, we've got flus and we've got COVID, coronaviruses, and we've got um, Ebola virus and, these different, what are they, filoviruses, but they sort of are punctuated, whereas HIV has been very, very consistently occurring, and even though there's been some relief, it does seem to be one of the longest running pandemics that you're right, a lot of people ignore.
Absolutely. Because if you think about it, in a country like Uganda, our prevalence has stagnated around 7%. And 7% is actually a lot. It's almost like I mean that means we have a lot of HIV, around 7%, and in the urban areas it's about 11%. So
Oh, that's
essentially
huge. That's a
that is
massive number.
absolutely. And this is the same in a lot of countries. And the other
Mm.
thing about HIV is that even when someone is treated, it doesn't cure, and they have the ability to transmit it to another person. And so
Mhm.
that is just a perfect environment for a disease to remain in existence. Things like measles would have been the same, but with diseases like measles, you have vaccination for it, which we do not have for HIV. So yes, it has been, I believe, the longest, most persistent pandemic to date.
And I want to ask you kind of a controversial question because this is something that, from where I stand ideologically, sometimes I will debate individuals here in the Western world. Very often, whether we're talking about HIV, whether we're talking about Ebola, whether we're talking about coronaviruses, you will hear a sort of, I don't know how to put this, and I don't want to bias your answer, but you will hear a response from some individuals, even very often progressive, liberal minded individuals, who will sort of victim blame and say things like, oh, there's so much distrust and there's so much resistance to treatment. And that's really the problem, is that we have to work on stigma. And I'm not discounting the fact that stigma exists, but that's not really the main problem when it comes to infectious disease, right? It's access.
Yes. Absolutely, it's access. So stigma was a huge thing in, for instance, HIV. It is a bit right now, but
Mhm.
I believe that we've found ways to go around that. So in most HIV providing health facilities, we have what we call either expert clients or peer counselors. And these are people who have HIV, they are public about their status, and they talk to people who come into the facilities, and some go out into the communities and talk to people in the communities. And so the issue of stigma has really largely been addressed. Most of the time when people these days come late for treatment, it's simply a question of access. They're
Mhm.
either they're either too far away from the healthcare facility, or it is usually something to do with access to care.
Right, right. I
Yeah.
think that there is a an idea, and it is based in truth, but I worry that it's exaggerated. Let's say Ebola, for example. You know, there's this narrative that in some of the Western African countries where there have been, larger Ebola outbreaks, that you've got these white, Doctors Without Borders, these aid workers who come in these like bunny suits and go into people's homes and take away their family members, and then their family members don't return. So there is clearly then going to be a resistance to, I don't want to go with you. When people go with you, they don't come back. And that is, devastating and horrifying. But I think very often that turns into some sort of, again, very paternalistic Western colonial narrative of like, oh, people are afraid of white people and that's why they don't seek treatment, when really the treatment's not available to individuals. Like, it's not
Yeah,
like there's a pile of vaccines, for different infectious diseases that's just left untouched in a warehouse somewhere. You don't have the same problem like we do here in America, where people are just actively saying, I don't want to get the COVID vaccine, even though I have it freely available to me.
absolutely, Kara, you're spot on. And I remember when I was doing a community health, some of the things the people in the community would tell me is that even when you go to the hospital, there is no treatment. And yet there's a lot of
Mm,
inconvenience going to the hospital because someone from your family has to come and be your caretaker. It's not in the like in the Western world
mhm.
where you have nurses that are going to be really on your beck and call. In this case, someone from the family has to come out and be with you in the hospital. You're not the treatment is not available most of the time. And so people sometimes decide to stay at home. They're like, what is the difference? Why don't I just stay at home? And we had it with COVID as well. A number of people, including some of my colleagues, were saying, you get to the hospital and you find that they're out of oxygen. So why go and die away from family? And yet you could have stayed at
Right.
home and died with family. Exactly. So it's about access to physical access to the facilities. But even when they're at the facilities, most of the facilities, unfortunately, are completely under resourced.
Ugh, and even when it comes to preventable childhood diseases, I mean, how often do you see the same story where a child, who has whooping cough, for example, or mumps or rubella, or these diseases that in the West very often people are like, oh, that was like my great grandparents' era. I've never even seen a case of these issues, because every baby is vaccinated against them. You have children dying of these in- preventable diseases, right? Simply because there's no access.
That's true. And sometimes what we are seeing is that when you provide access to people where they are, the uptake is much
Mm,
higher. So with the
right.
research project that I was involved in, one of the things that we had started doing was taking cervical cancer screening to the communities, as well as vaccination against cervical cancer to the communities. And what we found that was interesting, Kara, was so the average uptake of cervical cancer screening in Uganda is 5%, right? But
Oh,
when we
yeah.
took the services to the communities, the first time around, 99% of all the people who were eligible took up the service. And the second
Oh,
time we went back
wow.
with exactly. The second time we went back with more funding. So far, there was, by the time I left, there was no community where anyone had come and not taken up the vaccination or the
Oh, that's
cervical cancer screening.
incredible.
Yes. So sometimes you just need to take the services to where people are because there may be constraints that are preventing people from coming to the health facilities.
Well, and I think one of the things that's very often not talked about, I wish it was talked about in every single conversation, and I'm making some assumptions because I'm coming from a very privileged Western perspective where we continue to struggle with these issues, is just straight up sexism. Like when it comes to cervical cancer, this is a disease that only people with cervixes get, right? So even though all people can catch HPV, only women have cervical cancer, or men with cervixes as well, right? Transgender individuals.
Yes.
But ultimately, there is deep, and I mean, this happens across the globe. There is a deep amount of sexism that I can imagine would prevent women from access, whether it's that their husbands don't think that they need it and they prevent them from going to travel for it, whether they are sort of bogged down with childcare responsibilities, but that just simply being women prevents
Yes.
us very often from medical care.
Absolutely. And Kara, you're speaking like someone who has read the survey instrument that we use. And those are some of the reasons a woman wants, I know she wants to go for screening and the husband says no. She wants to take the children, says no. Or the children need to go for vaccination. She's very busy. The husband doesn't help her take the children. Or just things like people being afraid of infertility. They're like, what if I get infertile? Then I will be an outcast in the community. So it's all
Mm.
related to being a woman and what culture says about women.
Yeah. Yeah. Gosh,
Yeah.
there's so much to unpack there. We're starting to sort of get towards the end of our time together. And so I'm not sure if this is going to be a very clear question, so bear with me. But I'm curious personally, as somebody who has trained in these different, very social justice approaches to medical care and medical treatment that have a very strong research and epidemiological component, and I should say public health component to them, now moving into this role as the research director of a charitable organization that is a very, very evidence based, what is the fastest and most efficient way to get people the help that they need? Is there's a clear crossover that I see, but you in some ways have your toe less in the sort of medical world now than you did before. And so I'm just curious what the transition has been like for you. Are there things that you miss? Are there ways that you are sort of straddling both of these interest areas? I'm just curious where your head is at with regard to this kind of big career change.
Mhm. I'll start with what I miss. I really miss interacting with patients. I mean, I just love the interactions with patients, getting to know them as human beings and being able to help them as a physician. So I really miss that
Mm,
component. But when I move to give directly and look at the work that we are doing, giving people cash to enable them to have access, for me, that is for me, that gives me a reason to remain with Give Directly because now
yeah.
people who couldn't go to a health facility, could not afford medications, are able to afford it with the cash that they're receiving. We're actually starting work in Malawi with Medicine Sans Frontier, MSF, and it's called Cash for Health. And very interestingly, this cash is going to people with HIV and people with cancer. And guess what the most common cancer is? Cervical cancer as well. So that
Mm,
sort of brings it full circle for me. However, it's been a very steep learning curve, I must say, because I came to Give Directly with no background in development economics, but it's been a great learning path. I'm learning it's made me have to read a lot, watch a lot of videos on YouTube, but also interact with my colleagues who are economists. I mean, my research manager called Andres Parado, amazing person, and I'm learning so much from him as well. So I love the challenge, and I
Oh, I
think
love
everyone at some
that.
point of yeah, so I think everyone at some point of their lives should experience this kind of pivot. It's absolutely amazing.
Oh yeah, yeah. Kind of switching gears. I myself personally switched gears later in life. I went back to school in my 30s. I was a neuroscientist and a public science communicator, which I still am. But I went back to school to study clinical psychology, and it's amazing how much working towards this PhD as a older student has shown me. Uh, it's amazing how transferable the skills are when you learn a new skill set, how much it applies to everything else that you knew, and now you get to see it in a new way.
Absolutely. Absolutely. It's funny. One of the assignments that my immediate supervisor gave me when I just joined Give Directly was focused on how best to target people in poverty. And it's interesting. I just used a method that I found that the method that they use in development economics is one of the methods that we use in clinical epidemiology as well. And I thought that was absolutely amazing. I mean, things like area under the curve. I was like, this is absolutely amazing. So you're right. There's so much that is transferable across the disciplines.
Uh, I love that. I've been saying I love that a lot, but I do. I love that. So, Miriam, I have to ask you. I'm going to ask you two things. So, I close every episode with two major questions, and so I want to do that first, and then at the very end, I want to talk to you just for a quick minute about how individuals listening to the show can get involved. But I want that to be the last thing we say. So, before we do that, I'm hoping that you are willing to play ball and answer the two big picture questions that I ask every guest on the show that come from every different walk of life. So it's always fascinating to hear their perspectives. Are you ready for these two kind of, I don't know, deep questions?
Fire away, ready.
I know. I'm like, whoa, what a preparation I just gave you. Okay, so the first one has to do, well, they both have to do with the future. So in whatever context is relevant to you. So this could be very personal, it could be very community based, it could be the future of the type of work that you do, or it could be a much more kind of global or I don't know, even cosmic perspective. So whatever context feels relevant to you right now. Number one, what is the thing that keeps you up the most at night? The thing you're most concerned about, worried about? Maybe you're even bordering on on cynicism or pessimism. And then on the flip side of that, where are you finding hope? Where are you finding optimism? What are you truly looking forward to?
Right. What keeps me awake at night? So I grew up
Mm,
in Uganda and lived through three wars. I was too young to remember, through four wars actually, too young to remember two of them, 8 years old when two of them happened. So for
mm,
me, what keeps me awake at night is honestly the fear of civil war. And it
mm.
worries me when I see how a lot of the world is dissolving into crisis. I mean, look at Ukraine. Who could imagine? So that
Right.
worries me a lot. And especially since I have four amazing young children. And sometimes I am working and saying, what if war breaks out and the children are in school? How will my husband and I reach out to get them? So I worry about that. And then also, will the world forget? I have seen a lot of wars where it just continued happening and the world forgot about it. In northern Uganda, we had insurgency for 23 years. And even in Uganda, most of Uganda had moved on. People didn't know what was happening. Look at cases like Southern Sudan. Look at Ukraine right now. Most of the media sites are not even reporting on Ukraine right now. And my worry is, if that happens, will people forget? And why are we forgetting that there are so many people in the world who are just like us and are going through these terrible humanitarian crises? I mean, the countries I've mentioned are just at the tip of the iceberg considering what else
Yeah.
is happening in the world. So that really bothers me a lot. I know it may be a form of post-traumatic stress disorder for me, but it does bother me a lot.
Mm,
What about optimism? Kara, I think people are good. People are good. There are so many people who are good people. There are people who are kind to others, people who are willing to give to help other people. And for me, that is a huge source of optimism, because even those who don't want to give learn from those who give. I mean, when we look at some of our donors in Give Directly, they have absolutely no reason to give. They don't have relatives who come from these countries. They don't even have friends coming from these countries, but they're taking their money and giving it to Give Directly and other aid organizations to help people. And sometimes people say, oh, these are really just the high net worth people. They have like billions of dollars to spare. But no, we have people who are everyday people like you and me that are giving parts of their monthly salaries to causes like this. So that fills me with a lot of optimism. There are a lot of good people that are living in the world right now.
Mm. Absolutely. Gosh. And how wonderful that you get a front row seat to that. That in those moments of
Yes,
despair, that in those moments where it is sort of hard to see the light of day, that you have this reminder that you can look at the data, that you can kind of like open up a spreadsheet and go, wow, a lot of people do care and a lot of people are really trying.
absolutely.
Ugh. So I have to ask, for those who are listening right now who really, really do care and who want to give back, what is the protocol? What should they do?
Great. So, like I said, Give Directly receives cash donations from what we call high net worth people, people who have a lot of money, and then from organizations as well. But then we have a lot of donations that come from the everyday people. The best way to do this is simply to go to the Give Directly website, which is givedirectly.org, and there is information on how to donate. And there, it's very straightforward, very easy to donate. I would also encourage you to subscribe to the Give Directly newsletters that gives updates on what we are doing in the communities. And also, we have a program where people can give cash transfers, and we let you know which household your cash transfers went to. And in that way,
Mm.
you can actually literally almost see your money moving from your pocket or your bank account to a specific individual. So there's information on all of that and how to get involved in all of that on our website.
Oh, that's amazing. I'm looking at it right now. This is just such an important opportunity. And thank you so much for taking the time with us today, not only to tell us about your journey and your story and the incredible work that you've been doing throughout your career, but also about how such a fundamentally easy, is that an okay thing to say, just
I
clean, easy,
Yes,
straightforward
absolutely.
approach can really, really work in the favor of the individual recipients.
Yes, yes. Thank you. It's been great talking to you, Kara.
You as well. And everybody listening, thank you for coming back week after week. I'm really looking forward to the next time we all get together to talk nerdy.